So let's get started. I'll pass it over to Monica Chadwick. She can say a little bit about herself and dive right into the presentation. So thanks so much.
All right, thank you for joining us. So we want to go to the next slide. Today we're going to talk about a paradigm shift in mitigating severe pressure ulcers and deep tissue malpractice claims. And to give you a little history, let's go to the next slide. I first met Dr. Fife, or I heard her speak many years ago at a wound conference. It was a symposium for advanced wound care. And at the time, I was working as a legal nurse consultant at a law firm, and we had a lot of skilled nursing cases that we were defending in litigation. And I heard her speak at this conference, and it really taught me that there was a lot more to wounds that I wasn't realizing when we were evaluating these cases. As a nurse, I'd done plenty of wound care as a home health and hospice nurse, and I really thought I had a pretty good understanding of wounds and how they evolve and all of that. But when I heard Dr. Fife speak, it really taught me that we need to take a closer look at the way we're evaluating these cases. And, we would typically just look at a case and we've got a wound, and can we show documentation that the resident was changed or repositioned every couple hours? And if we couldn't show that in our documentation, then we just kind of moved to, all right, it was our fault, let's settle it. And in listening to Dr. Fife speak about the physiology and taking a deeper dive and looking at these cases, it truly was a paradigm shift in the way that we defended cases, and understanding that we really have to understand etiology and how these wounds evolve over time. And we really can do a much better job in defending these cases. So I'm very excited to get to share her knowledge with the rest of you. I tell people I'm kind of the Vanna White of this presentation. I'll set it up, and then she's really what you came to hear. But it really did change the way that I understood wounds. So I'm very happy to be able to bring this information to you. So first of all, let's talk about defending pressure ulcer claims. We have a variety of people on the call today. I know we have some clinical, we have some legal, we have some claims folks. But for those of you that have defended pressure injury claims in the past, you know how they're a problem. You never are excited to see a case and see you've got this huge ugly wound that you've got to defend to a jury. Other issues in defending these types of cases are just the documentation issues alone can be a mess. Wounds change over time, their treatment changes. We've got documentation in a lot of different places, from physician orders to treatment plans to care plans. And it's challenging to make sure that all of that is in alignment. And more often than not, it's not going to be in alignment somewhere. There might be a new order change. It's not always written everywhere. So just the documentation in these cases alone is very challenging. The other thing that really comes into play in defending these cases are policies and procedures. And in my world, I primarily work with skilled nursing facilities. And I go around the country and I do risk assessments on these facilities. And one of the things I always do is I look at their policies and procedures to make sure that they look defensible should litigation occur. So when it comes to a skin and wound policy, how can that be defensible? And what are some of the pitfalls? I have an example. Just recently, I was looking at a policy from an organization, and their policy said that for wound care, they will meet and exceed NPIAP standards of care. I thought, what? what does that even mean? But why would you put that in your policy? And that, it sounds great to say that we're going to meet and exceed what's usually done, but what does that really mean? And how would you defend that policy? So what are you exceeding? Why wouldn't you just meet the criteria, what the recommendations are for standard of care? Why would you exceed it and do something different? How would you explain that? So when those policies are what we call overly aspirational in nature, to say, well, we go above and beyond, well, that can be problematic in defending those policies. Another thing that I saw in a policy where it said wound treatment orders will be initiated immediately. Well, that sounds great too, but we know in the real world, these facilities might be in a remote location. It's not like they just have a closet full of every wound supply you could ever want. So to say that, well, we will immediately implement new wound treatment orders In the event that you might have a wound vac or some very specific wound treatment, you're not going to be able to do those immediately. So it's really important to look at policies and procedures and make sure that you have policies and procedures that are defensible and reflective of what you really can do in realistic situations. Another issue is that the photos may inflame a jury. And this is what we always see whenever you get a case and you see these big, ugly wounds, you really have a challenge in convincing a jury that that big, ugly wound happened despite the best of care. They received great care. Care was phenomenal, but we still have this ugly wound that it's difficult for even clinicians to look at sometimes, but especially a jury to take a look at that and say, well, I'll buy that. I believe that can happen even if care is great. It's challenging to do. Another issue in defending pressure injury claims is that they may require multiple experts. And it's important to kind of have this understanding going into a case where you're defending a claim. Reason being that we're getting a variety of opinions typically in a wound case. So say, for example, you need to look at, was the wound care delivered as ordered? Well, that's going to be a nurse, your wound nurse, to give an opinion on standard of care. Was nursing standard of care met in the way that the wound was treated? But there's also going to be the need for an opinion about causation and the physiology of the wound and how did this wound occur and was it unpreventable? Your wound nurse can't opine on those issues. Those are outside of her scope or his scope to opine on those issues. Just like it may be out of the scope of your wound physician to opine on whether or not nursing standard of care was met. So you've got different opinions, and it's most likely going to take multiple experts. So that's why these cases can be cumbersome and very time consuming, and it's not a simple thing. Like in most med mal cases, you've got, a surgeon might have made a mistake and the outcome happened. And so it's pretty cut and dry, and a surgeon expert is all you need. These pressure injury cases are just going to be a little more complicated than that in most cases. I want to touch on this myth of not documented, not done. So, like I said, I'm a nurse. I've been a nurse over 30 years. Back when I was in nursing school, we were taught not documented, not done. And almost every nurse you could ask has heard this phrase before. And we were taught this because if you did it, you should document it. Show that you did it. You have to have documentation to support the care that you did. Well, we know that nursing now documents by exception. We don't document the ordinary. We do everything we do. We don't document every time we reposition somebody for comfort or we offer them water or everything. We don't document everything that we do, and we know that. We document by exception. We document the out of the ordinary. But this is still around today. I was sitting in a DON's office not too long ago, and she had a little placard on her desk that said "not documented, not done." And I said, but is that true? And from a risk management perspective, let me tell you how this can be problematic if this is what you're teaching your nurses to believe. If you ever do have a nurse that is called into deposition, and especially when you've got a wound case and they're being deposed and they're asked, well, isn't it true? Do you document everything that you do? And the nurse says, well, yes, not documented, not done. So if I did it, I documented it. My documentation is great. Well, that can be used against them then if the plaintiff attorney can show. So here we've got 6 hours that they weren't turned. By your own statement, you didn't document it, therefore we can assume you didn't do it. So this one little myth, this nursing myth, can really be used against a nurse if they're ever called in to be deposed. So I just want to put that out there. So hopefully I'm on my own little crusade to eliminate this little phrase, but just keep that in mind if you ever are preparing nurses, and specifically in wound cases, that this is what we were trained to believe. So make sure that this isn't used against them in a deposition. I also want to talk about causation analysis. So when I was first working at a law firm as a nurse consultant, I sent some records to a physician and I said, can you give us a causation opinion on this case? The physician said, I don't learn causation. That's not something I learn in medical school. cool. I've never used that phrase before. I don't know what you're talking about. And I realized that causation is one of those medical legal words that we like, but it's not necessarily what our physician experts are going to be using. So it's important. They're much more used to talking about the etiology of something, but etiology and causation are pretty much in alignment. So it's important to understand that they might not come back and give you a causation opinion, but it's just because that's not in their normal vocabulary. But it is critical in these wound cases to establish if a causal relationship exists and to look at all of the other issues that can impact that causal relationship too, and to really cast a wide net when you're looking at the causes of a wound and look at lab values and hydration status, and also really go back and look at where they were prior to coming to the facility. So I'm very used to seeing a resident coming to a nursing home, and day 2 or 3 of the residency, all of a sudden they notice these purple marks on their heels. And we think, oh boy, well, it happened. We first assessed it here. It's ours. It's our fault. It's so important to go back and look at what happened to them before they came to the facility to see if there are any other possible causal elements that might be out there. For example, if they had a hip surgery and they were on an OR table for a long time, or they might have just been on an ER gurney for a long time, or what else, they may have been on the floor at home after a fall for hours. So it's important to look at any of those other possible causal relationships that might have happened and have a clear understanding of where these wounds may have originated from, and get that opinion from an expert. It's also important to get the opinion about whether or not the wound was unavoidable, or the better term for this is medically unpreventable. That's something that Dr. Fife taught me as well. Medically unpreventable. From a medical perspective, this wound could not be prevented. And it's really important to get that opinion also from any treating providers. It's really nice when a treating provider themselves documents the wound as medically unpreventable. Reason being, in a case in litigation, we're always going to have plaintiff attorney saying, yeah, it was totally avoidable. Defense expert is going to say, no, it wasn't, it was unavoidable. When you have that third party, that treating provider supporting that it was an unpreventable wound, that's so helpful in defense of these cases. Like I said, look at prior records for signs of DTI, especially if there was ever a skin assessment that might have shown a little purple spot, or it might have shown a little something, and then maybe it wasn't assessed for a couple of days. You might be able to go back and really dive in to see if whether or not any alterations in the skin noted prior to admission might have indicated that that DTI existed prior to admission. It's also important to get an opinion about whether or not the wound is a Kennedy terminal ulcer. For those of you that aren't familiar with a Kennedy terminal ulcer, it's a wound that shows up almost overnight sometimes when you've got somebody with a terminal diagnosis that's in later stages of life, kind of an end of life wound. And the reason it's important to get an opinion, they're on the sacrum or coccyx. It's important to know if you've got a Kennedy terminal ulcer, because if it is, you'll have a lot of information and data to show that this is something that's part of the dying process versus an indication that there was insufficient care. And also understand that causation analysis is not the same as your standard of care opinion. You might have a great causation analysis that shows that no, there were other factors that caused the wounds, but your standard of care opinion might not be great. Maybe the nurses didn't do wound care as ordered, or there were delays in treatment. And the opposite can be true as well. You might have great standard of care. All the treatment was wonderful with as far as treating the wound goes, but your causation opinion might not be supportive of the defense of the case. So those are two different opinions that you need to get when you're looking at a wound case. I want to talk briefly about wound photography. As I said, I work with senior living clients. Many senior living clients are very hesitant to do wound photography. I would guess, in talking to my peers, we were guessing that less than 25% of skilled nursing facilities actually do their own wound photography. And when I ask them why, they say, we don't want it used against us. And I tell them that in all of the cases I've ever worked on with wounds, the photos exist. Somebody's taken the photo. It's going to be the hospital, the wound vendor, sometimes it's OMI at autopsy. More likely than not, it's going to be the family. And the family photo is going to show a wound that's the dressing saturated. It might just be following an incontinent episode. It's going to be the worst case scenario what the wound's going to look like. Also, they can take that wound photo and blow it up so that the wound looks like, it's the size of a pumpkin. If we have our own wound photography with measurements on it, we can show the actual wound size. So getting wound photography can really help defense of any cases. It also gives your expert the opportunity to explain the wound evolution. And as you hear Dr. Fife, we've got some pictures coming up for you. Explain how a wound evolves. When your expert has photos, they can explain that and tell the story. When they don't have that and you just have these narrative notes, it's really hard to know exactly what your wound looks like. There's also what happens sometimes is somebody's saying it's a coccyx wound, somebody's saying it's a sacral wound. You don't know if you have one wound or three wounds or what's going on, but wound photography can really make it clear as to what your wound actually is. And so that helps in defense of the case. But it can also be used to counter the photos produced by the plaintiff. You can have a clean wound, a wound that's been changed, and it really will tell your story versus allowing just using whatever photos are going to be used against you and not having something to counter that. So that's my 2 cents on wound photography. So hopefully more facilities begin to adopt the practice. But and with that, I'm going to turn it over to Dr. Fife to get into the physiology of these wounds.
Thank you so much, Monica. It's always a pleasure to speak with you. And I'm a physician. I'm not a risk manager or an attorney, so I'm going to be focused very clinically. My goal would be to try to give you some a new perspective and maybe some insights into the fact that you've been sold a bill of goods for a long time now. We might be able to talk about why that is. But the first bill of goods that you've been sold is the issue of the terminology. I'm not quite sure how the NPUAP, now called the NPIAP, has the total floor on this, because I'm one of the many physicians who disagrees with lots of things that come out of that organization. And yet everyone seems to be marching in lockstep, particularly around terminology, when in fact, Medicare and ICD-10 don't use the terminology that they use. So we've all been told all of these are injuries. It drives me nuts as a doctor. There's no way I'm ever going to write an order to pack an injury with XYZ. Like, it just doesn't make any clinical sense. So it's true that CMS views any closed lesion, which would be stage 1, and the deep tissue injuries, which they call deep tissue damage, views them as injuries, not ulcers. But and anything that's open, which logically in my mind means that it's an ulcer, is called an ulcer in Medicare's parlance. They're all still considered ulcers in ICD-10 codebook. And I'm so fascinated that if Medicare and ICD-10 consider wounds and ulcers to be separate concepts, with a wound being something that happens as a result of an accident or surgery, and an ulcer being something related usually to an underlying medical problem. And I get in trouble with coders if I use the word wound when referring to a diabetic foot ulcer, and they come running to me and tell me that I have to change my documentation and, behave. But yet, if we can put, or we're told to put, injury all over the chart, when that's not how the ICD-10 code works. I just find it fascinating that we've all had to buy into this terminology. I am going to tell you why the word injury might in fact be the right word, but not when there's actually an open sore. And of course, my concern over the whole concept of injury is that it does sound like we hurt someone, we injured them. I confess that I think that might have been part of the motivation for changing the term. But what I think doesn't matter. You have to deal with the reality of the fact that the word injury may be used in the chart, and it does seem somehow a confession. What I would like to point out, and I realize it's lunchtime, but maybe this is good for your diet. I just wanted to give you a visual image. If you haven't seen these, probably most of you have. to show you that a stage 1 and a deep tissue injury, by whatever name you call it, are lesions that don't have a break in the skin. And this, by the way, is one of the most powerful reasons why photographs can be valuable. And I'm going to explain why these are a form of injury, because in the case of that stage 1, they are ischemia reperfusion injuries. If we have time to dig into that a little bit more, I will. I also will tell you that that picture is my son's heel. And maybe when we get to the Q&A, I can explain to you how his case has provided tremendous proof that these are ischemia reperfusion injuries. Whereas deep tissue injuries may still be closed, but as I'm going to show you in just a moment, the tissue underneath has died, and that lesion is going to evolve. And I'm going to talk about this later in just a moment, but one of the big problems with having numbers, and by the way, you can use Roman numerals or you can use Arabic numerals for these, it doesn't matter. But one of the big problems about having anything that refers to numbers is the sense that it works like cancer and they progress through the stages, and nothing could be further from the truth. So maybe we'll have some specific questions around ulcers and injuries and we can talk about it a little more. But first, like Monica, I'd like to do some myth busting, because one of the ways you get backed into a corner, you get backed into a corner by having a nurse say, if it's not documented, it's not done. So don't fall into that one. But the other way that you get backed into a corner is that somebody in deposition will say, these are never events, right? And the answer is wrong. When you look at the actual Federal Register where these statements were put out, this was Medicare deciding they were not going to pay extra money for certain stages of pressure ulcers. They would be rolled into the payment amounts for the hospitalization for other conditions. What I want to point out is that Medicare, CMS, then made a list of what they call serious preventable events versus what are just hospital-acquired conditions. And I just want to point out that the hospital-acquired conditions include pressure ulcers, and not pressure ulcers are not part of the serious preventable events. So the pressure injuries or ulcers, and they use the word ulcer at this point in time, these are not in the list of never events. The list of never events includes giving the patient the wrong blood product, an air embolism during surgery, doing the wrong surgery on the wrong body part. Those are the never events. Pressure ulcers are not on that list. So don't get backed into a corner by having somebody try to tell you that these are never events. Medicare never said that. They simply said that they were potentially hospital-acquired conditions that had protocols that might decrease their likelihood. So that brings us to this other myth, which is that pressure ulcers are a priori evidence of negligent care. And that is absolutely not true. And we have a lot of literature, including clinical trials, to explain to us why that isn't true. And the one that I find absolutely fascinating is one that, as a wound care doc, I found by accident, because the person who was really focusing on this is a woman in California whose expertise was elder abuse. And she didn't know anything about wounds, and she was just asking the simple question about whether a full thickness pressure ulcer that happened under the best of care, whether they could happen under the best of care, and if they did, would they look different than the pressure ulcers that occur in cases of negligence. Laura Mosqueda is the Mosqueda, is the person who did this, and she did something that I still think is extraordinary, even though it was some years ago now, but she got the Department of Justice of California to fund a prospective trial looking at the best possible care. And they took 63 top performing skilled nursing facilities in California, and I think they extended into Washington State or Oregon in order to get the final number of 63. But they monitored these patients prospectively and documented that they all had the absolute best possible care that could be delivered. And they still had 24 residents that acquired full thickness pressure ulcers. All of them had cardiovascular disease or dementia. And she concluded something that everyone in the wound care industry would have said, well, we already knew that. But her simple point was, if they all look the same, whether they were from negligence or whether they were occurring in the best possible care. In a moment, I'm going to get to why the best possible care could still allow them to happen. That's part of the paradigm shift. But I just want to point out, and Monica and I can make sure that you have access to the papers that were published from Laura Mosqueda's research. So there's another trial. I'm afraid the picture of this particular trial is a slightly different one, and I want to focus on the TURN trial. And so this was a prospective NIH-sponsored study to evaluate this whole concept of 2-hour turning. It may surprise people to know that the original concept of 2-hour turning was not based on any human data. It was essentially a random recommendation that had no evidence base behind it. And yet it has become, the altar that we worship at. And so there are some misconceptions I don't want you to go away with about this this trial should have been published in JAMA or the New England Journal, and sadly, because all the people involved were nurses, they ended up in a geriatrics journal. But this was a very large prospective trial taking patients in multiple nursing homes and randomizing them who were at moderate or high risk, according to their Braden score, to either 2, 3, or 4-hour turning. And the short answer is there were no serious pressure ulcers, even in the high risk patients that were turned every 4 hours. And there was, in fact, no difference between turning schedules at 2, 3, and 4 hours. Now, what you shouldn't walk away from, and I was the safety monitor for this trial, not receiving any of the funds. I was asked to supervise it because I had the ability per the NIH to call a halt to the study if it appeared anyone was being hurt. What I want to emphasize is that before they began the trial, they went into these nursing homes, purchased very good high-density foams across the board, and got lots of extra pillows so that patients could be positioned comfortably and were on a decent, not a fancy electronic mattress, just a good high-density foam mattress. And I'm going to get back to this whole issue of just having the best possible scenario for pillows and a good mattress. So I don't want anybody to think there wasn't work that went into making sure that the standard of care was delivered in the best way possible. The focus here, however, should be, so I don't want anybody to walk away with what doesn't matter about turning. The focus should be that there's nothing magic about 2, 3, or 4 hours. And what was interesting was the percentage of patients in the randomized to 2-hour turn who demanded to exit the study because they were so tired of being bothered. It was interrupting their sleep. They were very unhappy to be randomized to that group. So there are a lot of factors that make these. There are 2 very large papers that have been published on this, and they should be in your toolkit if you are defending some of these cases. But the big take-home study, and oh good, I'm so glad we've got the link for Laura Mosqueda's paper. There's more than one. This was, I think that's the link to her actual Department of Justice report, but they also published peer-reviewed paper. But the moral of the story is that full thickness pressure ulcers can occur even under the best possible care. And there are some very interesting risk factors that I'm going to get to as we sort of work through this concept. I've mentioned the problem of the numeric nature of the staging, that it just, I bet there are lots of people listening who just think that pressure ulcers go 1, 2, 3, 4 because it seems logical, but that is absolutely not the case. And even the NPUAP would tell you that's not the case. They had always defined these stages as simply a way of identifying the deepest depth of the problem, but they don't even really do that. So there's a problem that you have to get past, both for staff, because lots of clinicians think this, both for a jury, for family members, that these numbers are not, if you end up with a 3, it did not start as a 2 or a 1. That's part of the problem, is that people will assume, well, why didn't you identify it before it was a 3? I'm going to tell you in just a second why that might not even be possible. But the numeric nature implies a progression from lower numbers to higher, which does not exist. And then I want to dig in a little bit more about this whole concept of maceration. And by the way, this is yet another reason why photos really are needed and can help you more often than they hurt you. So here's a scenario that can really happen. This is a patient that has irritation as a result of incontinence. It looks sort of like rug burn there. And these are described in the chart as being stage 2 pressure ulcers over the buttocks. And the first thing I'm going to tell you is that I bet you don't know this because it took me a while to figure this out. In 2016, the NPUAP changed the way that the staging system was implemented. And the only thing that can be a stage 2 is a ruptured blister, an intact blister or a ruptured blister. You can't have a wound that has that red hamburger meat, for example, or dead tissue. Those right here, this is since 2016, the things we're looking at here are actually stage 3s. But in this particular case, they were called stage 2s. And then months later, there is something that looks more like this. Now, if you have photos, you could look at that and go, well, those are clearly different things. But if the only thing you have is a chart that describes a patient as having stage 2s, and then months later says they have either unstageable or stage 4s, then without a photo, there's no way you can really make the case that these couldn't possibly be the same thing. They're obviously not the same thing. So this is one of the dangers of the staging system. It is also a reminder that when something goes away and gets better, it's just as important to document that it resolved. Otherwise, the assumption will be whatever happens next was just a continuation of that event. Maybe one of the most important messages we could transmit is make sure when something gets better, you say it's better or it's gone. Now, here's another example, and this is, I hope, going to try to help make the explanation about the paradigm shift that Monica and I want to deliver. So this is a patient who actually fell out of bed at home and broke her neck and was on the floor at home for, I think, 3 days before anybody found her. And this is the first time that anybody took pictures of her when she arrived. And that sort of ruptured blister was described as a stage 2, and because it's partial thickness, it's not all the way through. And so you might be able to say maybe that that's true. But that area of bruising or that dark discoloration is actually a deep tissue injury. And I'm going to show you what happened to this case. Now, remember, this is a woman who was on the floor for days. Then this is the first opportunity anybody had to see her. The record said these are stage 2s because of those ruptured blisters. There actually weren't comments made about the discoloration. Another reason that photos are helpful. Then what happens is all of this tissue starts to die. I'm going to explain to you in a moment why. And so now you have this black eschar. That black stuff is called an eschar. It's tissue that has died, where the skin has died fairly quickly, and dead skin and dead subcutaneous tissue are in the picture. And then gradually all of that tissue dies and is going to be cleaned out. And now you're looking at a very large wound that in her case actually exposed bone. So here's what the chart says. Stage 2, unstageable, stage 4. If you didn't have these pictures and all you had was that notation, the message that gets transmitted is these progressed. They got worse. And I will tell you, these did not progress. First of all, she had a deep tissue injury when she came in. And second of all, these evolved. They didn't progress. And evolution is a word that's very useful for you to have in your toolkit. And so I'm going to show you this in a little different way. This is actually the stump of a patient that I was taking care of for another problem. She had a below the knee amputation. And so you can sort of see, I hope you can see my arrow. This is the surgical site from her amputation. She was trying to learn to walk on her prosthesis. She comes in for a different problem, but I look at her stump and I see this thing that looks like a bruise. And I said, uh-oh. All right, that's it. No more PT with your prosthetic. We're going to take your prosthetic off. You're not going to wear it at all. You're going to be in your wheelchair. We're not going to let any other pressure happen over this area. And what I want you to notice is within about 11 days, it's a black scab. And within about 2 or 3 weeks, it starts to soften, and then boom, this thing opens up. So the first question I would ask you was, it took about 4 weeks to get to this point from that bruise. And the first thing I'd ask you is, how could we have prevented that? What intervention should we have done to keep this thing from happening? And the answer is, well, I already did it. We took away her prosthetic. We didn't let her put any more weight on it. And the fact is, this problem was the evolution of that bruise because tissue died on the inside. That dead tissue eventually works its way out. And then you have this really awful looking ulcer. But in fact, once you saw that dark discoloration, the game was over. The tissue was dead. All we could do is wait for it to evolve. It's a little bit like if you've ever burned your finger in the kitchen, you know, the first thing that happens is that it's red, and then that blister forms, and then the blister pops, and then gradually it starts to heal. Well, it's changing from the first moment that you burned your finger in the kitchen, but it doesn't look the same every day. It's following a path that is what the body does after certain types of injury. So what got me thinking about the way that we needed to deliver a different message was this patient. And there's a funny story about this. We might have time. I'm keeping an eye on the clock, but this gentleman's only 48 years old, but his BMI was, I think 44. I don't know if I put it on the slide here, but he was, there's a link to the paper. A massively obese gentleman who had coronary artery disease at this very young age. He had sleep apnea. He had ischemic cardiomyopathy. He underwent a coronary artery bypass surgery, which took 5 hours. And his mean arterial pressure was only about 50 during the surgery. That is low. The clinical folks will know that that's really low. And he also lost a lot of blood. He gets to the intensive care unit where he's clearly hypotensive for more than 12 hours, despite being on vasopressors. And if we have time, we can talk more about vasopressors. And on post-op day 2, he's turned over and he has a very large purple discoloration over his buttock. And by the time that I saw him, this is what he looked like. And of course, they send this patient to, they call me to see him. I'm looking at this and everybody's running around like, well, we're going to be blamed. And I look at the case and go, oh dear, all right, this is not our fault. But here's the problem. His sternum was already coming open. And so I said, we have this t-shirt. Let's not do this again, where we gradually let this buttock area get necrotic tissue, get colonized with fecal bacteria. Once the butt is colonized with the fecal bacteria, his sternum will colonize and then he'll die of sepsis. So I said, we're not doing that. I called the plastic surgeon and said, look, I know we don't normally do a debridement over what is still kind of an evolving situation, but this time we're going to, because I want you to clean it up so that we can put negative pressure wound therapy on it and run antibiotic or antimicrobial solution through it to reduce his colonization. So plastic surgeon does this. And after the case, I asked him how'd it go, and he said, you know, it went fine, except for this weird thing I noticed. There were these 2 holes on either side of the sacrum, and they had blood clots in them. And he said, I don't really know what that is, but I just want to let you know, like, there are these weird looking holes. So I see this man as an outpatient for many weeks, getting this very large ulcer gradually healed. And I can't take my mind off those 2 holes. And the other thing that is interesting is that he never got sensation back over his buttock cheeks bilaterally. So he had damage to the sensory nerves of his butt cheeks. And so as he began to heal and wounds contract, the area of his buttock cheeks that were affected sort of appeared to be closer to the top of the gluteal cleft than they were in the beginning. In the beginning, it looked like the most curvy part of his butt cheeks that were where the problem was. And so, you know, you have to ask yourself, okay, that Q-tip in there is in the last area to try to heal, which is one of those tunnels on the side of his sacrum. And these yellow arrows are approximately where that was in relation to his original problem. So this is another paradigm shift that has bugged me for years, in that NPUAP has always said, hey, these problems form because of compression, between a bony prominence and a support surface. And lots of us, I bet you have seen these very large areas of the fatty part of the butt cheek that gets these pressure ulcers. And yet, if you've ever said to yourself, wait a minute, there's no butt cheek bones here. There's the sacrum, but the fleshy part of your buttocks does not have a bone underneath it. So how is it possible for the fleshy part of your buttock cheeks to be affected because it was trapped between the bone and a support surface? And the answer is because that's not what happens. What happens is those holes that the surgeon pointed out to me are those holes there where the blood vessels come out of the sacrum to supply the buttock cheeks. The vessels and the nerves that supply the curviest part of your buttock are actually coming from the sacrum, and therefore the pressure that caused, and it's not, by the way, that no pressure is involved. It's just that the pressure wasn't over the fatty part of his buttock cheek, it was over his sacrum. And that is what had me thinking about angiosomes. And maybe later I'll have a chance to tell you my personal story about my son. But we've known about this concept called angiosomes for 50 years. And your entire body is a three-dimensional map of these angiosomes. They're fed by an artery and a vein that are big enough to have a name. And those numbers, by the way, are the names of the arteries. There's a key that tells you what the name of each artery is. And those arteries ultimately are coming off the aorta, and then they're supplying very large three-dimensional blocks of tissue so that your entire body ends up being a jigsaw puzzle, a three-dimensional jigsaw puzzle of blocks of tissue supplied by an artery and a vein big enough to have a name. And plastic surgeons have known about this for more than 50 years because that's how they design rotational flaps to cover up very large tissue defects. So this is an artist's conception of what these angiosomes look like. And you could also think of it like a tree that, if you've ever done any tree trimming, you can trim the leaves and you don't affect the branches. But if you snip off a branch, you could end up losing several leaves in a group. And if you lose one of the major trunks of your tree, then you're going to end up with a tree that looks like half of it is missing. The closer you go to the source, the more of a three-dimensional loss you'll have if you lose one of those branches. It's true for plants, and it's also true for pressure ulcers. If you block off one of these, depending on how big the vessel is, then, and by the way, it could be either the artery or the vein that is occluded, and I could make a powerful argument that in many cases it's the vein, then, and that's the reason that they look so messy. That man's buttock area, it looks like a shark attack because blood gets engorged. The venous return is stopped. The tissue dies as a result, and it's a very messy, messy injury. And the point that I would make is that if you look at any anatomical area where there's a deep tissue injury or a stage 4 pressure ulcer, and this is another reason that you need to have your own photos so that it's not just zoomed in right on top of things, it's far enough back you can get some anatomical landmarks. I challenge you to find one that can't be described by one of the angiosomes that's in that map. And I gave you a link to the map. They're always able to be described by the loss of the supply of a specific vessel that has a name. And when you then go look at the factors that make deep tissue injuries and stage 4 pressure ulcers more likely, and there are lots of publications, I just put one out there, but there are so many that I can't count them. Here are the factors that are associated with deep tissue injuries and stage 4 pressure ulcers: low mean arterial pressure, low cardiac output, low albumin, and I can talk about why that might be, peripheral vascular disease, being on vasopressors, having a fever, having low oxygen levels, being anemic so that you can't carry enough oxygen. Those are factors that are all associated with these deep tissue injuries and with stage 4 pressure ulcers. And the thing I'd like to point out is all those factors are factors that have to do with hemodynamics. They are not capillary outside in factors. They are inside out tissue dying factors. These deep tissue injuries in stage 4s are forming from the inside out the way an apple rots. We've all had this experience where you buy apples, you cut one open, and it's dead inside, but the outside didn't look abnormal. That is the process that is gradually taking place. And that is why there can be a lag time of several days, so that whatever really happened in the hospital, then they're transferred to your facility after some period of time. And exactly what that lag time is, we have a little bit of understanding, but nobody has been able to clearly define it. And then all of a sudden, when it finally works its way out to the level of the skin, everybody says, oh my goodness, look, there's a problem. And in fact, the problem began on the inside, worked its way to the outside. That took some period of days. And here's the other thing to remember is that if you cut the apple open and it looks like that, there's nothing that you're going to do to keep that problem from evolving, because the damage has already taken place. You just couldn't see it in the beginning. So that means that one of the things that we need to do is to change the expectations of the patient and the resident, and I call them patients that force of habit, but including the families. That is, and I was doing this when I was director of I was for a while director of the inpatient ostomy team at Memorial Hermann, until they decided that a doctor couldn't manage ostomy nurses, and they moved them to education. And what we were doing was working so well, we said, forget about hospital administration. We have a system that works. We're just going to pretend like they didn't try to reorganize it. But we would go to the ICU waiting room and meet with families and say, hey, I realize all these other things are going on. Don't want to give you more things to worry about, but your loved one has a very low blood pressure and is on medications to try to maintain the blood pressure, which cause constriction of the blood vessels to the periphery. And we are going to do our best to make sure that there's no problem with the skin, but sometimes that can happen no matter what we do. And that gets to this whole concept of medical unpreventability versus unavoidability. I just want to point out that unavoidability is actually a payment policy term. That is a term, as you all know, that decides whether you're going to pay money for an FTAG violation. Medical unpreventable and for the unavoidability, remember, it's all about, did you identify all the risk factors and then create a treatment plan to mitigate each one of them and prove that you implemented the treatment plan? And if you did all those things, then you get to say it was unavoidable. Well, medical unpreventability is a completely separate discussion. Medical unpreventability is around whether there was enough oxygen and blood flow to keep the tissue alive, regardless of what care you gave. So it's a very, very important, even if it seems to be subtle, it's a really important difference in the conversation. And so as these things are evolving from the inside out, they're happening because of hemodynamic factors. And by the way, I've never seen pressure ulcer prevention protocols, I hate that term too, that are geared at mitigating hemodynamic factors. We've had the same tired old things for 40 years around managing moisture and keeping patient skin dry and the same things we've been talking about for 40 years. And yet there is still a very predictable incidence of deep tissue injury and stage 4. And while this apple is just as good a way of illustrating it as any clinical picture, the deep tissue injuries are going to evolve into a stage 4 once the skin dies. That's what I was showing you in the woman who had the amputation and got one of these as a result of the tightness of her prosthesis. These are evolving from the inside out, and by the time you see the deep tissue injury, you can't stop them. The damage is already done. The difference is with stage 1s, those are ischemia reperfusion injuries, and the tissue may recover and the patient may not have any further problems. So just from the standpoint of Monica, you pitch in here too, now that we're getting to a little bit more of the legal care, because this is your bailiwick. But I agree with Monica. I've seen really almost sadly laughable care plans where, first of all, the care plan reads like we're going to turn this elderly lady into Angelina Jolie instead of making it clear that we're trying to make the best of a bad situation. But I've seen care plans that say, oh, this has to be implemented within 24 hours. The director of nursing has to be the one to sign off on the care plan, like things that just cannot realistically be implemented and don't necessarily mean that the care would be better if they were. Inflexible deadlines, unnecessary mandates, absolute wording, must, those are things, because that wording always needs to be based on appropriateness for clinical care and the other things going on with the patient. For example, in the neuro ICU, we have do not turn orders all the time because the patient's hemodynamically unstable or their CSF pressure is unstable. And we're making a decision that because the skin could recover and the brain and the kidneys cannot, we are prioritizing the brain and the kidneys, knowing that we might sacrifice the skin, but everybody would agree that that was a fair trade to make. So make the guidelines clear, give flexible deadlines, and make sure it's clear that there's discretionary clinical judgment. I personally hate the term prevention protocol because what does that imply? All of them can be prevented. I would call them mitigation strategies. But I think anytime we're sending the message that they could have been prevented, we're just creating not only unrealistic expectations, but just completely physiologically false ideas. And make sure you don't fall into the never event trap. Talk about medical unpreventability instead of unavoidability. Document all those comorbidities that may have been at play. And then I am very comfortable telling a family, look, we saw this thing. I know it looks like a bruise, but I just need to tell you the possibility is that there's been tissue damage. We'll deal with it, but we may not be able to prevent there from being some tissue breakdown. And one of the things that also that gets overlooked is that the body's own response, especially to low blood pressure. If you've ever had yourself fainted or had a loved one with low blood pressure, you touch the hands, they're cold and clammy. Why? Because the body is centralizing blood volume to protect the kidneys and the brain. So the body's own reaction to low blood pressure or trauma is to say, let's protect the organs that we can't live without. The skin can go hours without perfusion and still make it. And even if the skin doesn't, we can fix it. So the body is making that value judgment. And then if we put the patient on vasopressors, vasoconstrictors, we're just continuing this process of limiting or squeezing down the blood vessels in the hands and feet and the periphery to centralize that blood. And then everybody's shocked when there's a tissue breakdown. Instead, what we ought to do is celebrate, look, you know, your loved one doesn't have brain damage. We managed to keep the kidneys functioning. This was the judgment call we made. And aren't we glad that we made that call and not a different one? So I mentioned before how important it is to document resolution. If there's a tissue breakdown that is clearly due to moisture, that's always best to say that. And under the category of mitigation strategies, you know, documentation templates can be very helpful. Communication tools and expectations management can be very helpful. Monica, you pitch in here since I'm stepping into your territory and I'm watching the time. But I just want to make sure that we don't set ourselves up for failure for things that are hemodynamically impossible to avoid in some cases.
Yes, very well said. The only thing I'd like to add to that is when I see care plans that say the wound is going to heal in exactly 60 days, when you know the wound is not going to heal in exactly 60 days, avoid doing that. It's
oh
okay
my goodness.
to know when the wound is going to heal. It's okay. You don't have to care plan for that wound healing and try to look into the future. It's perfectly acceptable to say it'll be without complications or without signs of infection or anything else, but you don't have to care plan and guess when that's going to heal, because you could be, if there could be an assumption that that's what everybody thought it was actually going to heal by that, and it's not, just a guess, which it usually is.
Okay, I made it, Monica. We've still got 5 minutes for questions. I don't see any questions yet. I'm also going to check the chat. There's a Q&A, but Somebody has asked, would it be possible to obtain a copy of the NIH trial and the DOJ research? And the answer is yes. I'll make sure that Monica has the documents and she can distribute them. I think they should be in everybody's armamentarium for dealing with these cases. And I have to say, I'm not quite sure how we wrestle sanity back from the MPUAP. They know that I say this about them. They don't say nice things about me either. But what troubles me about that organization, and I know people who I do respect and trust who are trying to change the organization from within, but so many of the individuals with clinical backgrounds are plaintiffs' experts. And it deeply troubles me when I see things that seem to me to be helping the plaintiffs make a case and preventing the defense from telling a concise story that would make sense, then I'm skeptical. So I'm on a mission to try to at least get you the tools that you need to defend these. And I have told Monica, I will talk to any organization if I don't have to travel, no fee, just to try to get out there. The reality, there are lots, particularly physicians and particularly plastic surgeons, who can look at these patients and go, it's obvious that that's an infarction. It's obvious. And since nobody else is asking a question, I'm going to mention something about albumin. So remember, if you've ever seen anybody with an arterial occlusion, one of the things about an arterial occlusion that clinical people know is that you have something that tends to be white and cold, because once an artery is occluded, there's no flow, and it's very distinctly different than a venous occlusion. If I put a rubber band around my finger and just occlude the venous return of my finger, it's going to turn purple and swell, and eventually the tip of my finger will die because blood can't get into the finger because it's so swollen, but it will look different than if suddenly I don't have arterial supply. Well, lots of these, like the obese gentleman who had the heart bypass, look very much like they were venous engorgement where the tissue broke down. And that man's albumin was 2.8. So I think and there are lots of people, this is not just me, who think that what happens is when the albumin is very low, the intravascular pressure, the oncotic pressure drops precipitously, and it is very, very easy to occlude the venous side of an angiosome when the albumin is low. And that may be why albumin seems to be such a powerful predictor of terrible things. Many of us have reviewed cases, and it's a series of unfortunate events, but the tissue is all hanging in there until the albumin drops below 3, and then everything falls apart. And it's possible that oncotic pressure is the reason. And by the way, one of the other frustrating things is the reason these concepts aren't being aggressively investigated in the lab. When I published the first paper on this, it was turned down by one of the journals, and the reviewer's comment was, "This is not how we think it happens." Like, well, that would be the reason to publish a paper. It's like you don't turn a paper down just because it's not the party line. So until we can get a little bit of a different voice in there, it's going to be hard to get into the lab and study some of these things. But there are organizations that are trying to do that. Duke School of Nursing and some other places have taken this on to look at the hemodynamic factors. So eventually it will come, but it's an uphill battle. Monica, what else do you think we need to emphasize? I think we have 1 minute left.
It looks like we had a question in the chat. If I can just ask, it says, with deep tissue injuries, how long can it take before the damage to the underlying muscle is obvious in a skin assessment?
It depends on the part of the body. And it depends on lots of other patient factors. You can imagine if you have somebody who's 90 years old, who's very thin, very little subcutaneous tissue, very thin skin, that it could be hours. If you have someone who's got, if it's an area of the body with a lot of subcutaneous tissue, which, by the way, the heel is probably going to show up early because it's unforgiving. But depending on the area of the body, dependent on whether there's recurrent ischemia reperfusion, because what probably happens for some of these is it wasn't all at once. There was a low flow state, and then it recovered for a little while, and then another injury, and then another. So that probably within the span of the operation or whatever was going on, there were multiple sequential insults until they just couldn't handle it anymore. There's a lot of debate about whether these are on the order of hours or days. And the consensus opinion is that it could be either, depending on how sick the patient was, how much subcutaneous tissue there is, and were they malnourished? How were they volume depleted? All those things. And I want to say something else about, I know that doesn't help you, but we don't know the answer. But I want to say something else about volume. And that is, there have been hospitals that have piloted projects where all they did, because one of the things we didn't talk about since we are focused on subacute care, but there are, no matter how good the policies are that a hospital implements, there is an incidence of about 10% of deep tissue injury in stage 4s that is immovable. And that is true across the world and across the whole US. About 10% of these really bad problems, no matter how good the mitigation strategies are. And the reason is it's hemodynamic. And some hospitals have fought back simply by saying, if the patient is alert and can swallow, we're going to have them drink more water. Because if you've ever been in the hospital, and most of us have, you realize, like, I don't want to drink that whole bottle because I'm going to need to pee and I got to call for help because I can't get up. And a lot of problems end up being with patients progressively getting dehydrated, blood pressure drops, and then problems ensue from that point. Maybe we ought to think about actually checking blood pressure in some patients that are going downhill. And that, like, how are you going to defend that this was hemodynamic if there's no such thing as a blood pressure in your chart? Like, I think we're going to have a different kind of conversation about what it's going to take. And it might not be turning schedules.
Yeah, all very interesting. And we really, I think we could probably go on and on, it sounds like, with some great comments here. But it looks like we can wrap up with just saying thank you to Dr. Fife and thank you to Monica for the presentation today. As I said, we'll send out the recording and a couple of the links to the studies. Make sure everybody has that information. There'll be a short survey that will pop up when you exit the webinar. So we look forward to everyone's feedback. And thanks so much again, and everybody have a great day.
Thanks for having me. And thank you again, Monica, for letting me speak with you.
Thank you very
you
much.
all.
Bye, everybody.
Bye-bye.